Welcome, everyone. We are really excited to have you join us this year virtually. My name is Busoye Anifalaje. I am the Chief Implementation Officer at BAO Systems based in Cambridge in the UK, and I will be moderating this session. Well, in fact, am currently self-isolating, having been in contact with someone who tested positive for COVID. But fortunately, I only have 10 hours, 43 minutes, and 22 seconds to freedom. But then, who is counting? Anyways, without further delay, it is my pleasure to introduce this session describing a novel approach to immunization tracking in the context of highly fluid people migration, as is the case in cross-border populations. This, of course, couldn't be more topical as the world tries to grapple with vaccinations against this global pandemic. Our speaker on this topic is Dr. Bashir Ahmed, who is currently the Digital Health Coordinator at the Intergovernmental Agency for Development based out in Djibouti. Dr. Bashir has extensive experience implementing innovative cross-border health solutions whilst navigating the complexities of data sharing and security policies within a challenging deployment landscape. During the presentation, please do feel free to use the Q&A feature to ask questions. We will consolidate these questions and take them right at the very end. So without much ado, please welcome Dr. Bashir Ahmed.
Thank you, Busoye. Greetings from Djibouti to everyone. It's a bit warm here, unlike your side. It's been raining, it's good weather, so greetings, and greetings also from IGAD. I will start my presentation. It's a short presentation whereby I'll take you through a novel approach to immunization for cross-border mobile populations. Just give me 1 second to share my screen.
Dr. Bashir, yeah, you're on mute.
Okay, good. Okay, good. If you can see, then that's good. So I'll take you through by starting with the first slide, which is now basically our partners and the topic of discussion today. That is the lessons learned in implementing a novel immunization program for cross-border mobile populations. I have not indicated the region here, but it's within the IGAD region. IGAD, which is comprised of 7 countries in the Eastern Horn of Africa, namely our headquarters being in Djibouti City. The countries included are Ethiopia, Eritrea, South Sudan and Sudan, Kenya, Uganda, and Somalia. So as you understand that this is a very, the Horn of Africa is a very mobile population. Namely, when I say mobile, I mean that there's a lot of movement. It's a population of 250 million people, and out of the 250 million people who live within the region, approximately about 120 are nomads and cross-border mobile populations. With this in mind, came about that cross-border mobile populations, you had to take care of the cross-border mobile health. That is where the IGAD mandate is. And we came up with the help of our partners, this approach, which is a novel approach. It's an innovative novel approach, which shows now how children can access immunization across borders continuously. So if you look at the speakers for today's session is myself, Dr. Bashir, and Martin Weiss, who is the Jambi lead, who are also our partners in implementation of this. And I think from slide 1, you can see that this project, this pilot project was supported by USAID funding. We have Broadridge, who are our prime partners and technical partners. We have Duke University, who are assisting in the rollout of and the preparation of cross-border digital, a policy in cross-border digital protection policy. We have ourselves on the east coast of Africa. We have Gembi, who are the technical lead in the innovation for the healthcare innovation. And we have WAHO, who are the West African Health Organization on the other side. I'll jump straight to slide number 3. I will walk you through it by explaining that this is a solution that was brought about through a joint discussion between the regional bodies, USAID, and the technical partners. It is a regional solution for tracking immunizations for cross-border mobile populations. We initially have, the first pilot place is now the Kenya-Uganda border, which is Busia and Malaba. Kenya and Uganda, if you both know, are both on the East African side of the African continent. It is an offline system that is also online, depending on how you customize it. We have the basis of this technology is basically a contactless card. You know, it's like a Visa card. Actually, the end users now call it a Visa card, but it is a contactless card and is used both in everyday life. It's like your normal Visa, but it allows you to the personal health record of the care receiver is stored in this card. So the healthcare receiver can literally cross borders with their health records for them to access care in another country that are within the IGAD region. So immunization history is stored electronically on the card and in the cloud. When the patients on the mothers, because it's of immunization, under 5 immunization, the mothers are given, if you can see in the middle of the screen, you can see your start your journey, get your starter pack here. It's a starter pack that contains the immunization record, which can be labeled there, the BCG, the OPV, that's the immunizations that are given to children. It also contains a map of the facilities that support the cross-border facilities, which are on the borderlines that support this initiative. And it gives the healthcare receiver a walkthrough of what journey is about. The data is interoperable at all levels because it is based off open source, and that is the idea, so that we can have continuity and fluidity in the sense of now data sharing. The technology can be easily integrated into other immunization programs to ensure uptake without disrupting programs. That is, whether there's a health management information system set up for that facility or any other facility, or at national level, whereby national level, most of the Horn of Africa and East Africa, they do use the DHIS2 system, which I'm sure you're all versant with. It can be easily extended to include other health events, COVID vaccinations, HIV viral load checks, yellow fever. All that can be included into this card, which can easily be carried around. And the reason why we chose a card is because it is set up in a low resource setting. In this day and age, you can create easily an app and have everyone use the app. But then, since you're in a low resource setting, we have to think about the communities that live on these cross-border areas and which would they prioritize? Would they prioritize, getting a mobile phone which has an app and a secure network, or just, or a card that they can carry around? In that sense. Sorry about that. We implemented in October 2018 in 4 clinics on the border of Kenya and Uganda. We trained numerous, at the initial point, 8 health workers were trained, and those were the admins. And then they also trained the nurses at the facilities, the immunization nurses. So, and they have a continuous on-the-job training because, as you know, nurses go through rotations in different departments. So on that job training and that institutional memory of what the journey is about is very important, and it has been preserved through the admins. To date, we have issued almost 20,000 cards issued. We have done over 140,000 immunization events. We have a patient retention of over 97% continuously. Less than 100 cards have been replaced at the cross-border sites. As you can see, over 23 health workers have used the system to date. Downtime of less than 20 hours in total. Clinics and ministries receive regular reports that include immunizations, given cross-border trends for them to make decisions, clinical totals, stock information, as well as detailed healthcare provider statistics. This helps governments plan ahead in the region for forecasting. That is basically whether it's disease surveillance, whether it's procurement preparation, whether it is intervention for outreaches or immunization outreaches, specifically, for example, now that there's a COVID outreach immunization that is going on, it would be good to have an insight and an overview of what exactly is being given and at what point and what doses and when. This is basically just to show you contents of the starter pack. As you can see, it's a small park. It's not massive. It's very small. This is the map of the cross-border area. You can see the straight line in between that shows you, where and how the cross-border facilities are. The green dots represent the facilities and, how people can access them easily. This is the normal transportation facilitations at the cross-border area. As you can see, it's a poor resource setting, so you have to be very thoughtful and conversant with what and be amalgamated with the society around there. As you can see, there's also the constrained resources. There's no electricity as much, so we also included the solar system, solar panels to the kits that were being put into the clinics, so as to have continuous upload and download of data for use. The telecommunications, as I said, you can all see none of them has a smartphone. Most of them have the basic phone, which they can make a phone call with, just use it for an SMS or a phone call, and that's at most. And so it is very important for you when you're doing an intervention or innovation in a poor resource setting. You have to think about the community and what they actually their day-to-day usage of what kind of telecommunications are, what kind of phones they use. I'll play this short video that should show you how the system works or how it's used. Let's see. So. So I'll just play it again, just for clarity again. If you want to take a look, you can see it gives you the milestones, the weeks. So if you want to upload data, let's say you're given the immunization, you've saved the immunization of, let's say, at 6 weeks, the 6 weeks, 14 weeks, 10 weeks. You can add a child, you can view a child, and this all gives you information on, and the child can comfortably go with this information because, across the borders and continue getting immunization care, whether in Uganda, whether in Kenya. These are reports which are generated to your right under the facility. These are the reports generated. I think in the next slide. Okay, so this is, sorry. The local server. This is the box that is set up in the clinic. You can see the 2 phones down there. We give them 2 phones, and we give also a phone, an admin phone, just for the admin. This phone is for the healthcare workers. This server box is set up. You can see the servers there, just for the to get the data and save them there till when they can be uploaded. It's a Wi-Fi hotspot for healthcare, healthcare workers' immunization devices. It's a charging station for immunization devices. We even give them extra cables for them to charge the devices when they're on call. Local storage of health events, mains and solar powered. They have the internal batteries, the 2 black items there at the bottom, which have a 12-hour continuous operation, non-stop. We have not had any downtime from the boxes since implementation. That is what we're approaching 3 years now. So it's a very good, and it's very cost effective. It's very cheap to implement this in facilities, and it's been working well so far. So it is the future of this is extensible to host other applications. OpenMRS, for example, DHIS2 in its entirety. remote operational maintenance support, no healthcare worker intervention. That is basically put a GSM module into these boxes so that you can upload and download data as per needed. As you can see on the right, one of the healthcare workers, one of the nurses is looking at that. This is also one of our colleagues when this was set up. Slide number 10. The detailed health report. The detailed health report gives you the health impact, gives you the immunization events per clinic, it gives you immunization events per country, the cross-border visits that have occurred between the two countries. It can break it down to per day, week, month, and the healthcare worker. This is all analytics, which our technical partners support us with. We have the operational impact. We have the number of healthcare workers enrolled, how many use the solution, number of lost or replaced cards, any system downtime, that large information per device, server statistics. We have all the detailed reports since inception, and that is where we are at the moment. This is a more of an interactive PowerPoint, so I'm more than happy to take questions and go back to where we were before this. Thank you so much.
No, amazing. Thank you very much, Dr. Bashir. This is really, really very good. And we will be taking questions. I'll be coordinating that. But I have a few questions for you, if you don't mind. And there are a number of these. The first is, it's been absolutely amazing how many cards you've been able to distribute. And you had 20,000 cards. Is that a card per person, or do you have where the records are linked, like a mother with children, would they share a card per household, for instance, or is it strictly a card per person?
Thank you for the question, Busoya. It is actually a card per child. So
okay.
Every child is given a card. Whether it doesn't matter, as long as they're under 5 and they all came for immunization events, whether they're 3 children or 2 children, they're all given a card so that each can have their own personalized health record.
Okay, so this is effectively 20,000 unique individuals that represented in this project. So the following question is, how do you deal with identity? So how do I say there are 3 children in the same household, a child takes the card of another child, how do you navigate that?
Sorry, allow me, let me just get one of the cards out. I'll show you.
Okay.
So, for example, this is the card. I don't know if you can see.
Yep.
See the card, okay. There you go. So it looks like that and like that. So this is the most important bit, this QR code reader here. You can see this. Yep. This is the unique identifier for every individual. So that, even if it's 3 children from the same household, if each of them has their own unique identifier on their card, they can be separated, and they're, that's one of the unique identifiers. Because at that point, they do not have a national identification card, so they're not of age yet. So we do use the QR code as their unique identifier to, link them between the children. And this comes with their starter packs, and even if they lose it, the mother is allowed to come with the identifier with that QR code, and she can be given a new card for the child, even if they lost the child.
Okay.
Yeah.
So perhaps maybe I just need to. How do you know the person who is standing in front of you presenting the card is the person who should own the card? I think that maybe that is the question.
Yes, that's a very good question. Now that is why we're working on the policy, because we have not to the bit of now definitely identifying the person, whether it's through picture or through our fingerprint, and that would not still be allowed between the countries. Definitely nationally you can do that, because then you'd have the servers that you'd use that for, they would be hosted in the country. That would be straightforward, that would be easy. So now why we're doing the cross-border data sharing policy and protection is for countries to allow to now identify in real time, people or healthcare receivers. And this would be I get your question, because this would be very important during a COVID response. and who are you giving the immunization to, who's getting the immunization. Yes, and that is why getting the policy done is important. Okay. Yes.
That is actually very interesting, because does that mean that biometrics is not off the table then, in terms of identity, if the policy goes through?
As the region, we would then allow the member states to decide which would be their definitive measure of identification. We would not want to limit them to biometrics, because there is more ways of identifying now. And for us as the regional body, we support the member states to make the decision to which would be their unique identifier for cross-border data sharing. Would it be specifically a case study, whether it's for example, a multi-drug resistant TB case, that would not only be a biometrics, that would also be a health record shared with other countries in case the person crosses the border to continue medication, because that is a public health risk. But then again, if it's an immunization for a child who's getting BCG and OPV, he's not a very high risk in public health risk. So how would you then define which is your measure of identification? That is the question where we bring the member states to identify.
Yeah, absolutely. Thank you very much. And we're getting questions from the participants as well. So Jane is asking, what proportion of caretakers show up without the card?
That's a very good question. So what we did, we gave them, let me also pull out again. We gave them lanyards.
Okay. Very practical, really.
You can go home with this. You can put them on your keys and store them somewhere safe. And also, we gave them the opportunity that they could keep the cards inside the server box, because there's a space whereby above the phones where the phones are charging. We told them you can keep the cards there. That in that case, when you come back to work in the morning, you can just access the server box, because that's permanent. It's not going anywhere. You can get your cards from there.
All right. No, great. And we have another question that's from Mohini this time. What is the strategy for COVID management at the border areas in a national strategic response plan? And how is this solution being considered to support this effort? So how is your solution being considered to support the effort?
Okay. One of the interventions that we've done for the member states as EGAD and with support from donors, specifically the EU, is we were able to put up, how do I say, we got ambulances for the cross-border mobile areas for the spots, and then we supported the healthcare workers with more PPEs, more interventional therapies, in the sense of now what do they need, what as per need basis. So we were able to get ambulances, we were able to get PPEs for the cross-border mobile hotspots. We were also able to put up makeshift quarantine and monitoring centers. And when I say about this is what we did in the IGAD region. I'm not sure about the other regions, but this is sorry about that. From the office. So we were able to also get negative pressure ambulances for the IGAD region. So that is the intervention what we're able to do, and supporting the healthcare facilities at the cross-border level. So we pushed all these items to the cross-border facilities at the cross-border levels.
Okay, no, this is great. There is a question here though from Erioje Ojemeri, and asking, how do you retrieve client information in the event that the card is lost or destroyed?
Okay, that's a very good question. So I'll go back to the start, and then when we're giving them the starter pack, this starter pack. The starter pack comes with 4 QR codes. This 4 QR codes is something the mothers can stick anywhere. So luckily, in Kenya and Uganda, all the mothers have to have the immunization card, most of them, so that they can, it's because that's the first identifier for any healthcare facility. you have to have a physical identifier. So this QR codes are stickable. You can stick them anywhere,
Okay.
We stick them to their mother and child care, the RMNCH, the prenatal book, for mothers where they're given their weight before birth, all that. We put this there. We put this one on the back of our phone. This other two, we tell her, go home, stick it somewhere whereby, where you put your money under the bed. In case you lose it, you can bring that. So this identifier then helps us to retrieve the information for that patient and give them a new card.
Okay. So again, you've built in redundancy. Just in case one is lost, they have others, and they don't keep everything in the same place.
Yes.
Okay. Sergey is asking, so how do you capture events on the people when they migrate out of the project area?
That is a good question. And that is where now, whereby the question of now expansion comes in, because for you to capture cross-border mobile populations, you have to cover a vast area. And that is where now we're in the process of, resource mobilization for expansion of the pilot, because it's been a success. We want to look at and how can we put it into other areas, because now you look at countries like South Sudan and Sudan, whereby the pastoralists move between the two countries every 6 months. Every 3 months, they go up north for the pastures. They come down south after 3 months. So you have to understand that whole Karamoja triangle. How do they move? When do they move? At what point do they move? So once we have all this data, we already have it because we did a landscape analysis. Is the only second point is now for expansion. So I hope I answered Sergey's point by telling him expansion is the solution.
Yeah, actually, this next question is probably very closely related to expansion, and this is from Martin Weiss, asking whether the program will be able to scale to also track COVID immunization. So from a programmatic area, is it hard coded, or how easily can it be expanded to track COVID as well?
That's a very good question. So it's very easily it can be integrated very quickly. It's only basically that is something that can be done very quickly, because you see most of the member states right now appreciate the fact that you have to travel to their country with a negative result. So if you can have your negative COVID result stored in a card, and it's updated when you go from Kenya to to the UK, and you end up in the UK and they see your negative result, they tap on it and they see a negative result. Then after 2 weeks in the UK, you do your test again in the UK, you come back to South Africa, and in South Africa they view your card again and says, oh, COVID negative result. I don't want to say the word COVID passport because everything
exactly.
But then this is your personalized health record, which should allow you to move around without limitations.
No, great. Now, Mohini's asked a question which I also had on my list. So I'm going to just fast track that question now. How did you go about establishing a data sharing agreement between countries for this sort of program?
Okay, so what happens is that between the two countries, first of all, IGAD collectively makes decisions with the member states. So the member states who are part and parcel of it lead the front in decision making. That's said and done. This agreement is basically it's a cross-border data sharing agreement between the two countries through IGAD. The IGAD was the representative for the two countries to say, oh, you know what, this is what we want, and we intervened. We interacted with both countries for them to give us now the go-ahead on the intervention and how to data share, specifically on how to data share. So we do have the MOUs and the agreements on our side on IGAD, and the member states have full access and information to this. And the most important thing for us is that this data is aggregate data. It is data that you can easily PHIS2 you can get off. So it is aggregated. It is not refined data now to an identifier, unique identifier to a person. So it's an aggregate data that gives you an oversight of how many BCGs were given, how many cross-border events of OPV were done. So that can give you a.
There are two follow-on questions to that, actually. The first is, how often is the data sharing agreement meant to be revised and reviewed, or is it a standing sort of 5-year, 3-year, yearly? I'll let you answer that first.
One is that, at the moment where the one that we signed, it was a 3-year agreement, so it is actually up for revision at the end of 2021. But we are hoping once we get the policy up and running and then the member states endorse and ratify it, which we hope should be done within the month of May, because we are already in the final draft of the policy, so we're really way ahead. I think that policy work would be groundbreaking for, to be honest, in Africa and also for the Horn of Africa. That would allow countries to now better have oversight, insight, and be disease preparedness for the next pandemic, because our region is also very endemic to yellow fever, chikungunya, breakouts, all that. So just to be prepared for the next pandemic.
Oh, great! Thanks for that. Arioje is asking a question which I think also dovetails into the second question which I had. You mentioned that it's aggregated data, but you have a card per person. So I guess at the point of service, you are collecting de-identified data, and then in the reporting, that's when you're aggregated, because at some point you are actually collecting data at an individual record level, right?
Yes. Actually, when you give them the card, but then you see the idea is that this data, their de-identified data stays with them. It is we don't store it. We do not. Okay. The card with the name and the only thing that we keep is the QR code, which is, you cannot, it's a unique identifier. It does not have a name. It's not associated with anyone. It's just that when they come and the right QR code will then give you the right person's name. So that is the definition, that is the delineation. But this is basically their personalized health record in their pocket. It doesn't have to be shared with anyone else.
Okay.
The only thing that we keep is now the QR code to identify, to give them a new card when they come back.
Yeah, so technically you cannot have duplicates because you cannot have duplicate QR code. But we do have a question from Areoje, and that is, what process of deduplication of client records is involved if a client is registered more than once? And I would interpret that as, if a client ends up with 2 QR codes, maybe 2 cards for some reason, either in the same facility or in another facility, maybe they've received a card from one facility and then they go to another, receive another card. Maybe that's a scenario that is possible. Well, is there some deduplication QA that works?
That's a very good question. Well, so far we've not had that situation, but I will mark that. I will raise it up on something that Martin Weiss, my co-presenter. Well, I would raise that with him, and then we'd look at it.
Okay. Yes, I see. Martin is also asking questions, so he's putting you on the spot. But no, this is great. Now, one question: you mentioned the EU sort of funding here for the project. In your
this project, it's for COVID
for the expansion.
COVID response.
For COVID.
About COVID. Yeah, so it was just the EU was supporting us on cross-border sites to get them PPEs, ambulances, and whatnot. So, I was answering that question about the COVID.
Okay. I mean, when you talk about sort of innovative technological solutions like you presented, one thing at the back of people's mind is, how sustainable is this thing outside of external donor funding? Would you say that each member state is contributing something towards the sustainability of the project itself?
Actually, the very interesting thing, the bit about this is that most of the member states actually wanted for something else. In Ethiopia, they wanted to roll out teenage HPV vaccination. In Uganda, they wanted it for the HIV, TB at the refugee camps. So it's very pluggable and programmable to the situation. For Kenya, they wanted to use it for universal health coverage in that sense of now it would be the basis of understanding. So it's good to look at it as something that is a solution that is very easy to deploy and very easy to scale, and it's cost effective. It does not look at it's not all expensive servers and whatnot. It's very easy and very light to use, and it works with everything. It's very, even going forward with the IGAD region, we're basing whatever we've learned, whatever we have from this project onto the next digital health interventions that we will have. Okay.
Yeah, and since you mentioned servers, this is the first presentation in my entire professional career that I have heard that, a server is cheap and it's easy to do, and there's no problem. and you showed the picture of the local servers. Can you speak a bit more about the architecture of those local servers? Presumably, you're capturing some data locally and then you're syncing to a cloud server. What is that setup looking like?
That's a very good question, but I think I would let the technical guys, but I don't know to answer that bit about the server. It's just that all I know is that the servers, for one, for now, is that we would look at servers being till the policy is in place. We would then look at what we're doing is cloud servers in the cloud, not in the cloud, but cloud serving. Okay. And then what we'd look at is also for the storage of this data, we'd look at it as a national level, whereby you have a server in Uganda, you have a server in Kenya, because you don't have a policy cross-border data sharing yet. So you can only store this data in the two countries. You understand? So the architecture of it is something I would be more than happy to let Martin and Wayne and Frank answer those questions, but I was not able to get them on today.
If Martin is on, he could request to share audio, and we could, because I think this is actually, in terms of infrastructure, this is absolutely critical for the success of your program, because unless you can access that data centrally somewhere, you really cannot identify the QR code and link them to the individuals, right? Okay. So anytime you are able to, just in case Martin is listening, if you're able to request access for audio, I will grant that access. So on the basis that the summit is about impact first, right? And you had a slide that was showing impact. I was wondering, do you have maybe some numbers or more description around baseline, where pre-intervention and then sort of post-intervention, what kind of impact are we talking about? With 20,000 was the number we had, with 140,000 sort of immunization events. But before that, what was it like?
At the baseline, okay, there was actually no. When we did the baseline study, there was literally no data for cross-border interventions or cross-border immunization, because it was the unspeak. This. Let me define this to you. Sorry, a border is a delineation of two nations. Yes, but if you imagine the communities that live along those borders live, there is no border to them. So on Monday, they would basically have the market day on the Uganda side, and on Thursday, they would have the market day on the Kenya side. So it's a community that lives together. And then you see that those days on Monday and Thursdays, you have a lot of immunization events, because the mothers bring once they come to the market, the mothers also bring the kids to the clinics. You understand? Yeah. So, and when these immunization events are happening in both the countries, there is no like, this is a Kenyan, this is a Ugandan, delineate. No, they're all given the same service. So then nobody gets down to understand that, maybe 30% or 40% are Kenyans on the Uganda side, or 30%, or, for every 10 mothers who are getting immunization events, 3 or 4 are from the other country. There's nobody who actually did that. So that landscape analysis showed that, there's actually a big gap in resources for the nations, because the countries keep pushing the resources to the cross-border areas, and they don't have a true picture of what's actually going on. Okay, so that's why I'll give. But we're more than happy to share the landscape analysis that we did before that.
Okay, no, this has been absolutely fantastic presentation. Really, really very engaging and riveting stuff. Well, I want to thank you. I think we're about to close, just in case anybody has any last minute questions. But just to let everyone know, these sessions are also recorded. You can, if you missed anything, you can come back to here. You would see the recording. There is, you have a few minutes between now and the next session. It's about 20 minutes, and you can look at the expo while you're waiting for the next session. You can listen to some nice jams, some music in the reception area. You can do some networking if you wanted. But before we disperse, I just want to take the opportunity once again to thank Dr. Bashir for such a wonderful presentation. Thank you very much.
Thank you so much. Amazing work, Busoye. And I'm happy, my email is there, so anybody can reach out. We can have discussions. Thank you so much for making time.